Good morning, everyone. Welcome to CBR. The topic of my today's talk is animal models of Parkinson's disease. So basically, in our lab, we are mostly focused on non-motor symptoms of PD. So however, I'll go through different aspects of animal models, how these animal models are induced. So if you look at the distinct features of any neurodegenerative disorders, Parkinson's is the most common movement disorders with motor as well as non-motor symptoms. So if you look at the particular region where Parkinson's disease is getting affected, it is substantia nigra. And you see there is a degeneration of substantia nigra in the postmortem tissues of PD patients. So if you look at different aspects of disease pathogenesis, what happens in Parkinson's disease is this substantia nigra, which basically has dopaminergic neurons, projects into caudate putamen, which is we call as striatum. And there is an axonal degeneration in the striatum, and there is a loss of dopaminergic neurons in substantia nigra. So if you look at the part of midbrain, we have two distinct regions, that is VTA and SNPC. So SNPC degeneration is basically when it starts, you see observing motor symptoms in the Parkinson's disease mouse. So what is the current management strategies are aimed at symptomatic relief of the disease. There is no pharmacological breakthrough, even PD for many years apart from giving levodopa. And maybe the current research should mostly focus on protecting dopaminergic neurons and associated circuitry components. So with that, if you look at the different trajectory of the Parkinson's disease symptom, you look at, there are mostly in the prodromal phase, you see premotor symptoms, which will have constipation, RBD, insomnia, EDS, and depression. And then you will have motor symptoms, and which is followed by more complication of psychosis. So for our interest for basic science people, what outcomes we can relate into molecular mechanisms is most important thing. So for us, if we see certain symptoms of motor and non-motor symptoms, we can correlate it back to the loss of dopaminergic neurons as well as the molecular mechanisms. So the translational research using laboratory animals should focus more on these behavioral symptoms, which will have which can show the trajectory of Parkinson's disease. And we need a powerful tools to potentially to concentrate on therapeutic and neuroprotective mechanisms, and mostly at the prodromal phase. So we are more interested in those prodromal phase of behavioral symptoms. So there are many mice models which are used, like mice, rats, primates, and there are many drugs which are used, neurotoxins are used, pesticides are used, and genetic alterations are used, alpha-synuclein inclusions have been used, and viral injections are being used. But actually, no model actually replicates the full pathology of PD. We often use two different approaches to get the full array of the symptoms what we see. So if you look at different types of mouse model across the globe, we have different chemicals like 6-OHDA, MVTP, protinone, and paraquat, which are used to replicate the disease. And we have genetic model manipulation of alpha-synuclein, LLRK2, PINK, Parkin, and DJ1, which are used as transgenic model. And now there are many emerging models which actually use both of these combinations to understand, because more of now, any neurodegenerative disorders, if you look at now, the more importance is given to the immune system. So we use both of these models to look at how immune systems are involved in the pathogenesis of PD. So if you look at how these different drugs and psychotic drugs which are initially used in the PD, how this affects the molecular mechanism is the first drugs which were used was Respirine, which used to inhibit VMAT, and then it was haloperidol, which was used to induce the blockage of D2 receptors, which basically blocks the docking or the release of dopamine. These were the first drugs which were used to induce Parkinson's disease symptoms in mouse. Later, MPTP, which is widely used neurotoxin, which is found to be a component of heroin that acts through glia. MPTP is converted into MPP plus by astrocytes, and then it is taken up by DAT transporters, and then it brings out mitochondrial dysfunction. And there are many other genetic models which basically comes from the genetic mutation of A53T, A30P, as well as LRRK-GB1, which I already mentioned, and pink. These are all transgenic models, and these few are chemically induced models. Apart from this, there are rotenone, as well as paraquat, which also brings about PD-induced pathology. So coming to the work, what we are doing at CBR, we are interested in molecular underpinnings of behavioral symptoms, which is basically non-motor symptoms, and disease progression in animal models. So basically, we use two models because we have some background on MPTP, which we have done earlier work. And then we are using transgenic model, basically A53T, as well as alpha-synuclein overexpressing mice, which expresses wild-type alpha-synuclein. And what we are interested in is the nigrostriatal pathway, basically, which involves substantia nigra, striatum, hippocampus, and cortex. So we are basically hypothesizing that if there is a decrease of these dopamine neurons in substantia nigra, which would affect the cortex and hippocampus. And this would happen much earlier because once the neurons starts dying, it will just retracts the neurites from where it is forming the projections. So with that background, Dr. Sandeep, who first started this work with MPTP in last, I think, 2 years back, he actually really struggled to get different doses of MPTP, and finally we got 10 mg per kg body weight, which would reflect that full trajectory of PD symptoms. And if we start giving MPTP at day 1, we see the non-motor symptoms by day 14, 15, and 16. Then we see the motor symptoms, which is at day 30 to 36. And then when we sacrifice these mice at 60 days, we see there is a behavioral deficits and biochemical analysis, and then we do histopathology. What we see is there is a difference in the non-motor symptoms at day 15. There is a difference in the motor symptoms at 30 days, and there is loss of dopamine and alpha-synuclein increase at day 60, which actually recapitulates the pathology. So if you look at the progression of PED, the prodromal symptoms start at first or second stage of BRAC2, where we see, usually we should be seeing the non-motor symptoms, and mid-stage. And late stage, you will see the blown-up pathology. So what we are interested in, whether we can make this as two parts and see how, before degeneration, if the projections are getting affected much earlier. So we have done many non-motor symptom tests like anxiety, depression, and many of these symptoms are shown to be, anxiety-like behavior are being shown to be higher in MPTP mouse compared to the saline. But we don't see the typical pathology of increase in the alpha-synuclein and phosphosynuclein and loss of DA neurons at the day 15. So this makes us a very good time point to see what happens in the striatal regions, whether we see there is a loss of synaptic terminals, or there is any changes in the synapses at that time points. And then when we come to 60 days, we see that there is an increase there is loss of TH, basically. And then there is an increase in alpha-synuclein and phosphosynuclein. And there is also loss of DAT fibers, especially the nigrostriatal tract is lost at 60 days, which shows the full-blown pathology. So with this background, what we plan to do is that we want to evaluate the excitatory and inhibitory neurotransmitters in different regions of brain to better answer how these neurocircuitry mechanisms are involved, whether their transporters are affected, whether the excitatory and inhibitory neurotransmitters are affected and these two regions, and how it contributes to early non-motor symptoms of PD pathology. And we also want to look at how alpha-synuclein aggregation at synapse, basically the alpha-synuclein is presynaptic protein, so we want to see how it contributes to such neurocircuitry pathway, especially in case of non-motor symptoms, and what are the mechanism, and what is the reorganization which alters the availability of neurotransmitters and the transporters. And this is the focus of the lab. I have just given you the flavor of what we have done, the basics, and we are doing all the alpha-synuclein part and the different dopamine levels and the neurotransmitters level in these models. So with that, I would like to acknowledge ScanTrust and CBR for their generous funding. And the initial work was started by Dr. Sandeep, and most of this data is by his work, and this work is continued by Hari and Manaswi, who's a graduate student, Rihab, who takes care of all the histopathology work, Dr. Shobha is taking care of alpha-synuclein work, and Shisha is our vet. So I thank you, all of you, for your patient listening.
Thank you, ma'am. Any questions? We have time for 2-3 questions. Anybody?
Latha, nice talk. So when you look at intervention in this and looking for rescue, is there points that you identified in the entire scheme where there are point of no returns and things like that, where you feel that certain symptoms can be rescued at a particular intervention and at later stage, because that is also important in the context of the disease?
Yes, so that is the idea really, whether we could protect the dopaminergic neurons when we see these non-motor symptoms. That's all we are looking at. So what we think is that if there is these non-motor symptoms, especially, we cannot really replicate. Most of the MCI-like behavior, like contextual fear conditioning, other things, what you do, we don't see it in the first trajectory of the disease, what we see. So what we think is maybe if we could rescue anxiety-like behavior, and if we could see whether there is a difference in the neurotransmitters, like we have some initial literature saying that GABAergic neurons express differently in striatum in these when there is anxiety-like behavior. So these are few highlights we have. So we would like to see those kind of markers and see whether some intervention would rescue at that time point. I mean, that's what. Maybe even if we could save DOPA, and give at when the motor symptoms emerges, is the what strategy we could use, is something what we are looking at.
Thank you.
Latha, very nice talk. Just wanted to ask you if you see Lewy bodies like alpha-synuclein as aggregated alpha-synuclein or just plain upregulation?
No, we are not seeing the typical punctate alpha-synuclein. Not typically like Lewy body in this dose of MPTP. We just see there is an increase in alpha-synuclein and there is increase in phospho. With Western, with immuno, both phospho and alpha-synuclein. But we are not seeing any Lewy body.
Right.
Maybe we have to use rotinone.
Or you could, rather than using phospho-alpha-synuclein, probably you could do a degeneration protocol so that you see the insoluble alpha-synuclein. You're using the soluble alpha-synuclein protocol.
Yeah.
Ma'am, during your beginning of your talk, immunological issues or pathways also you were saying you are applying. But application of all those things in these kind of models, is there any specificity?
Yes, the MPTP shows some kind of inflammatory responses. And we are planning to do some microglia and also different, whether it regulates or whether it upregulates reactive astrocytes and things like that. That is in the pipeline to see. But
and the pathways.
Literature have shown that it MPTP induction upregulates neuroinflammation. But at what dose we are giving, because what we are interested is in basically non-motor symptoms. We are not really pushing it to go to that pathology where you see everything is fried and you see there is loss of dopaminergic neurons. No, we are not interested in that part. So that's why at this trajectory, at what time point we see inflammation is what we are trying to see. We have at different time points, see 15, we have at 30 days also some data, we have some data at 60 days. So at this trajectory, where the inflammation is going to play is what we have to first check. And then, how much it has an influence on dopaminergic terminals as well as dopaminergic neurons we need to see. And then look at different immunomarkers.
Further to think of, is there any possibility of interventions also if you happen to
Yes,
find it?
yes.
That's
I mean, that's what is the idea. Like first you establish that trajectory and see at what time point we can have that intervention. I mean, that's the idea of having such a trajectory. It is not only in MPTP, even in alpha-synuclein pathology also, we want to do it at different time points to see, at what stage you will really see, axonal projections dying.
Okay.
So that, the intervention can be planned much earlier.